First of all, I'd like to thank Arup to have given this opportunity to me. Thank you very much. It's always a pleasure and honor to be in his course, and they're always very challenging. I loved ma'am's presentation. I'm going to talk about IOL calculation with very short and long eyes. So modern day cataract surgery, the refractive procedure has to be 20/20 is what our patients expect us to have perfection. So averagely what we have found in ophthalmology is that 78% of the patients have a target of zero point 0.5 to 0.6% of surgeons have 84%, and fewer than 1% of surgeons are at 92%. So this is a data given a long time back by Dr. Warren Hill. About 250,000 surgeries were calculated, and this is what was the conclusion. So while there's a possibility that yes, we can hit bullseyes in most of our cases, so normal axial lengths we consider between 22 and 24.5. So what's beyond this? So of course it's a crime like a jigsaw puzzle to solve it if you have a jig and you have a saw. So this is what was a very old thing. It's very, very crucial is accurate biometry and accurate formula. So we need both of them together. You can see the Asian tools which are there and modern tools which are actually just, you can see a huge difference between the two, and that's how we have to solve. So as far as biometry is concerned, ultrasonic biometry, optical biometry, intraoperative aberrometry, according to me, contact biometry should be banned. It should be only immersion biometry. We should not do contact biometry at all. And this is a big advantage you can see about optical biometry and ultrasonic biometry. The biggest disadvantage in ultrasonic biometry, it measures the axial length along the anatomical axis, while this measures along the visual axis, and more accurate, we know that is the posterior staphyloma. Optical biometry will really help. And if there is a compression or a depression on the cornea, the whole measurement is really going to change. So measurement or error, right, can actually cost you a 1 millimeter corneal compression can cause an average error of 2.5 diopters, in long eyes of 1.75 and short eyes of 3.75 diopters error. So that, according to me, compression or contact biometry should completely not be done. You should only do immersion ultrasonic biometry if you don't have access. We all know what is a good scan, a single peak, no peak, ACPC, all the echoes that you see, no peak in the, so you should not see any echo in the vitreous. This is what we ultimately want. If you see any echo in the vitreous, this is a poor scan. So you can see in the middle, if you see any of them, then it's a poor scan and this should not be seen. So there is ultimate conclusion that optical biometry is the best way to go. We have multiple optical biometers, the NIDEC AL scan. We also have the Aladdin, which is from Topcon. We have the IOL Master, we have the Lens Star, and we have the Galileo. All of them are actually optical biometers. And the swept source optical biometer has distinct advantages. The major advantage measures keratometry, axial length, central corneal thickness, anterior chamber depth, lens thickness, and white to white. So this is one measurement which will give you all the data at one shot. And of course, it will also look at the fovea. So sometimes if you have a little mature cataract and you have this kind of a biometer, and if you have a hole in the macula, it can be detected at the same time. Otherwise, this would be missed. So swap source OCT again is the best way to have, measures anterior posterior corneal curvature and gives you total keratometry, and also takes measurement in denser cataracts. So question here is which formula to use. So mirror, mirror on the wall, which IOL formula is the best for all? Yes, let us calculate that older regression formulas, the SRKT1, the SRKT2, the new versions formulas, different variables then came in the Barrett Universal and the Holiday. So this is how they've invented. But here, let's look at this summary. Axial length, K reading, anterior chamber depth, white to white, and lens thickness. You can see that the Barrett and the Holiday 2 does reasonably quite a bit of calculation. The Haggis does not have the white to white and the lens thickness. So classify formulas based on how to calculate eye power calculation. The Hill RBF takes data from the whole world, analyzes, and then gives you back an answer. This is how it works. And they also take into consideration neural adaptation. There is formula based on ray tracing is the Olsen and the Fick optics. And these are also there, that is there in the market. But when it comes to conventional teaching, so average eyes, which is 22 to 24.5, we normally used to do the Holiday 1. Short eyes is the Hoffer Q and the Holiday 2. Medium eyes, so 24.5, 26 and above, we have Holiday 1. And extremely long eyes, also the SRKT really works. So this is our conventional teaching. So the third generation formula then came into action where we have variable axial length and keratometry. They assume that what used to happen in the older times that when you measure a small eye, it presumes that a small eye has a shallow anterior chamber and a long eye has a deep anterior chamber. This is what it actually did as a calculation. But this is true in a very small percentage of people. So here, if you look on the left side, anterior segment size, large, normal, and small, and you look at megalocornea, and in the center, short eye, normal eye, and long. So you can actually see from this chart that how much is the variability in anterior chamber depth, not only depending on the axial length. So we cannot go as a blind procedure that yes, all short eyes have a small or a narrow anterior chamber. Special problems in long eyes is that the optical biometers tend to measure the axial length higher than actually it is supposed to be. And some very long eyes cannot be measured. Like I have a lens star, very long eyes sometimes does not come because they say that the gate on the lens star is closed and the IOL master may take a reading. And sometimes these may need a Van Koch axial length modification, and the modification on the axial length is of a 0.83, depending on the measured axial length that we really get. So special problems in short eyes, yes, small errors in measurements have much greater impact in short eyes because the smaller the eye, the more the impact and more the calculation, more the difference in the expected lens position. So short eyes are more susceptible to small variations and effective lens position. Therefore, a typical error can happen in short eyes. So there was a comparison between 7 formulas, the Barrett Universal 2, Haigis, Offerq, Holiday, Holiday 2, Olsen, and SRKT in 18,000 eyes, 500. And it was concluded that the Barrett Universal 2 had the lowest prediction error compared to everything else. So here also you can see that the Barrett and the Olsen read reasonably well in short eyes less than 22 and long eyes more than 24.5. Then there was another capacity formula comparison between Holiday 1, Offerq, SRKT, and Haigis in 69 eyes and short eyes less than 22. And this concluded that Haigis formula actually provided the most accurate results. So this chart actually says it quite a bit that short eyes, yes, you have the Olsen and the Barrett 2 and the Holiday 2. The long eyes, the Barrett 2 and the Olsen works very, very well. Or you may need to do a VK, that's a Van Koch adjustment, if necessary in long eyes. This may not be necessary in short eyes. So to summarize, in extremely short and long eyes, modern day formula perform much better. So I know that in short eyes, the Haigis, the Offerq, and the Holiday 2 do very, very well. I also use the Hill RBF, but the Hill RBF, you have to feed the data in the computer. It has got the data from all over the world, and then it tells you a conclusion. Additionally, some studies have shown that the Haigis with optimized A constant may be preferred formula in short eyes where the axial length is less than 22 millimeter and an ACD of more than 2.4 millimeter. So to summarize, overall in eyes with axial length more than 25, I think the Barrett Universal 2 or the SRKT or the Van Koch adjustment applied to the measurement of the axial length will work very, very well to prevent any myopic shift that may come out of the calculation. So this works quite well in long eyes. So steps to optimize the outcome in extremely is of course optimize your A constant, validate your measurements, and do not remove, spend extra time in counseling to the patient that your eye is not a normal eye and this may just take place. I'll just show a small video of small stuff. Now this was a micro-ophthalmic eye and I just want to show you.
With high hyperopia was referred for refractive correction. On examination, her best corrected visual acuity was 20 by 40 part in both eyes with a correction of plus 12 diopters. On slit lamp examination, she had a normal size cornea in a very shallow anterior chamber, and gonioscopy showed occludable angles with a normal IOP. She underwent a prophylactic YAG-PI in both eyes. A dilated fundus examination revealed heaped up optic nerve head and retinal vessel tortuosity with an attached retina in both eyes. OCT macula was normal in both eyes.
A detailed time is up, so we'll just tell you the end thing that I put a 65 diopter article in this case.
In the left eye.
And the patient did reasonably. I think my time was up. Thank you very much. We put a 65 diopter IOL in a micro-ophthalmic eye and patient did extremely well. Thank you, Arup, and thank you, ma'am, to have asked me to participate in the course.